Good morning. It's an honor to be here today and to discuss one of the more challenging topics in general otolaryngology. My name is John T. Lanza. I am a general otolaryngologist in St. Lucie County. I've been in practice approximately 25 years actually, in a general otolaryngology setting. I'm going to take you through my experience with dealing with head and neck tumors over the next 20 minutes or so. I'm going to keep the presentation quite basic, and it is geared towards advanced practitioners, specifically ARNPs and PAs. So let's begin. Head and neck cancer, and what I'd like to call this presentation is what you need to know for the front line, is primarily centered around squamous cell carcinoma. The incidence of head and neck cancers is a little ambiguous. Some reports say it's in the arena of around 80,000 a year. Some report 200,000 a year. But for our sake, it's anywhere greater than 100,000, which means it is quite plentiful in most general ENT practices in the state of Florida. In our practice, the leading etiology is viral, primarily for the base of tongue and tonsil, and that's the tumors we're seeing most commonly. When you think of risk factors, historically we think of head and neck cancer being due to or attributed to a history of smoking and or chewing tobacco with the addition of alcohol. However, viral contributors, specifically human papillomavirus, is actually becoming the predominant cause of the cancers that we're seeing in the head and neck in our area, with the exception of those in the larynx. Larynx, it still seems to be most likely consistent with a history of tobacco use. However, just for the sake of completion, there are other contributors or causative factors that need to be thought about. And folks from the Indian continent, there is a known use of betel quid, which they chew, and that's been associated with oral cavity cancers, buccal mucosa, gingiva, and lingual tongue. Then there is industrial exposures linked with squamous cell carcinomas of the sinonasal tract. And lastly, folks of Asian heritage have an association with nasopharyngeal carcinoma. In today's lecture, we're going to concentrate primarily on the oral cavity, that is, starting with the lips, buccal mucosa, palate, soft and hard, lingual tongue, floor of mouth, gingival ridge. Oral pharynx will include the tonsils, posterior fold, the posterior pharyngeal wall, the nasal cavity and sinuses, the nasopharynx, the hypopharynx, the base of tongue, which is now becoming a high prevalence site for cancers in our practice, larynx, cervical esophagus, and proximal trachea. When you're examining your patients, you got to do your best to not just inspect what is easily accessible. You need to look at the base of tongue, and for those of you trained in flexible or rigid endoscopy, the hypopharynx, larynx. Don't forget to palpate. Put on gloves. You should get used to palpating the tongue and even the tonsillar area. Soft palate, retromolar region, in the gingival-buccal groove, in the gingival-lingual groove. Feel the floor of the mouth. Understand what are normal variations so that when you do come across something, you'll appreciate the fact that it doesn't belong there. Next slide is, we're going to limit our discussion to those sites, and we're going to be aware of other tumors that occur in the head and neck. However, we're not going to include those in today's discussion. Each of these sites would require their own lecture, specifically salivary glands, benign and malignant parotid, submandibular, and the rare sublingual tumors. Diffuse lymphadenopathy, primarily those that are associated with lymphomas, thyroid disease, both benign, malignant, and goitrous changes, metastatic lesions to the head and neck. In the supraclavicular area, you can see breast, you can see lung, you can even see occasional prostate. So you have to keep those in your differential. It's not the kind of thing that we need to get into great detail today. As I said, each of these topics can have their own lecture. Cutaneous tumors, when you're evaluating your patients with a high neck node, make sure you do inspect the scalp. Many times there could be an underlying melanoma or squamous cell carcinoma in the scalp area. Parotid tumors are predominantly benign, and they are quite common in our practice. Thyroid nodules as well, but again, we will not be addressing them in detail in today's lecture. So for head and neck cancers, what do you really need to know for the front line? You have to be attentive to changes in appearance of mucosa. Any wet, white, red, or dark lesion in the mouth, be suspicious about it. Ill-fitting dentures. Patients will come in and they're carrying their dentures or their partials, and I can't get them to fit, and that could be a first indication if that's where you need to look for an underlying tumor. Unilateral nasal obstruction could be the presenting sign for a sinonasal cancer. Deviation of the tongue, paralysis of the innervation to the hemi-tongue resulting in deviation means that you really need to start palpating the tongue. Put on a pair of gloves, feel the tongue, be suspicious of the tongue base. And of course, any mass or swelling throughout the face, head, and neck, you have to be suspicious for head and neck cancer. So essentially, be observant and be diligent in your exam. Head and neck cancers, their presentation and their symptoms include not only the lump in the neck, not only a sore that doesn't heal, but it can also include ear pain, a unilateral ear effusion, trouble swallowing, throat pain, voice change, sense that they have a foreign body in their throat and they can't clear it. This other presentation can include a relentless cough with or without hemoptysis. So make sure you do a bimanual palpation on the neck and areas of concern. Inquire about hearing issues. Inquire about voice change. Is this your normal voice? So always be suspicious. The take-home message is be suspicious always. When the pieces of the history and the exam just don't fit, do not blow it off. Do not say, okay, I'm going to create, you have an infection, and I'm going to give you an antibiotic, and discharge that patient after 10 days of antibiotics, and therefore they're going to feel like, okay, there's nothing really wrong here. The antibiotic gets them partially to feel better, and then they just ignore their symptom for a few more weeks. Always bring back the suspicious patient in 3 to 4 weeks. Explain to them that on today's visit you don't appreciate anything to be worried about, but that you share their concern for their well-being and that you would like to see them at least a second time for another look. So the next few slides include clinical pictures. You're looking at a 72-year-old female with a non-healing ulcer in the right mandibular gingivolingual groove. You could see that there was an ulceration that's right in the gingiva surrounding their dental implants. They thought they were just dealing with an infection. They sat on it a little bit. They finally went to their dentist, and then the dentist eventually did a biopsy, which came back invasive squamous cell carcinoma, and then asked for our opinion for definitive care. This unfortunate next lady is an example of someone who developed a neck mass and ignored it, and then developed a second neck mass and finally came in for evaluation. She's a 73-year-old lady with multiple neck masses of the right neck. You can see there's a visible scar in the skin. She had local skin cancer resection by a dermatologist, and then decided that, she just wasn't going to get evaluated at the point of one mass. She needed for the second one to occur. Both of these are metastatic squamous cell carcinoma, but not of the overlying skin cancer. She has a right hypopharynx, base of tongue tumor, in addition to what you see on the neck. This is another example of a 66-year-old male who came to the office complaining of tongue pain. And on examination, you notice there's an ulceration in the left lingual tongue lateral edge, adjacent to the molars. And the patient says, "Oh yeah, I thought I bit my tongue." And then you feel it, and when you feel it, it's more than just an ulceration from tongue trauma. Essentially, there is some tongue trauma, but he was biting the tumor that was in the left lateral tongue. The tongue pain was present for approximately 8 weeks. So the next slide is a voice change in a 70-year-old male presented for evaluation of intermittent trouble with voice, which then became a persistent voice change. And you're looking at a papillomatous type of tumor sitting on and replacing the right true vocal cord up to the anterior commissure, and it has already begun to cross over and is now involving the left anterior 1/3 true vocal cord. This is somebody who first noticed foreign body sensation in their throat, and then progressively worsening voice change. Next slide is a 54-year-old county employee, worked outdoors, was in the sun all day, involved with road repair. He wore a handkerchief over his face, and presented into about the third or fourth month of the COVID pandemic. And no one even knew that he had the problem because of the face mask that he was wearing. Fortunately, we were able to resect this in conjunction with our plastic surgery colleagues who did an actually beautiful Abby Estlander flap on the repair. We were able to get clear margins. The tumor went down and did involve the submental nerve on that side. We ended up with a significant defect, but the reconstruction was actually marvelous. This is a 67-year-old male who complained of tongue swelling. Tongue swelling was present for about 3 months before he finally came in. Next is a 78-year-old female who thought her change in speech was attributed to her history of TIAs and CVAs, and as it turns out, she had a rock hard mass in the base of tongue. This is a 58-year-old male who thought he had some bad allergies until he developed daily nosebleeds for 3 straight weeks. That's when he came in to have us take a look. And again, the take-home message is be suspicious always. You would like to biopsy areas if possible, as early as possible, and you have to think about your imaging options. In my practice, it's primarily ultrasound of soft tissue neck and CT with contrast to the neck. Typically, if a patient presents with a single neck mass and no identifiable mucosal disease, I'll consider an ultrasound of the neck mass to get a better understanding from my radiology colleagues of what I'm really looking at. Am I looking at something that's cystic, solid, what it's adjacent to, if it's a lymph node, what are the ultrasound changes within the lymph node that are either more suspicious for malignancy. And then if there is suspicion and no definitive mass can be appreciated, and yet you're dealing with a high-risk individual, a CT scan with contrast. Getting that baseline CT is very, very helpful, especially if you're dealing with a tumor that you can't palpate, something in the hypopharynx, something beyond your grasp of the tongue base, or even the larynx. So the dilemma really starts with once you get that information and you're presenting the news to your patient. Remember, making the diagnosis is just the beginning of the journey that this patient's about to start. Now, if your initial workup is negative, meaning CT scan does not detect, the ultrasound looks totally benign, remain suspicious. If it's positive and you need to give someone bad news, remember it's still okay to hold someone's hand or give them a hug, and it is appropriate to embrace them still, despite what we're being told with COVID. And you're helping to guide them through the process of managing their new diagnosis. Fortunately, most cases are successfully managed long term, and the patient needs to know that you are on their team and that the prognosis is not dismal, although their journey will be very challenging. Things that you want to give them to control and have a sense of control are encouraging them to maintain good nutrition, maintain good oral hygiene, help them remain in control of their own bodies to the greatest extent possible. And just a brief talk about the appropriate options of definitive care. We'll use typically some combination of surgery, external beam radiation, chemo, and now biologics, and in certain circumstances, vaccines. So before anyone heads to the exit, and for those of you at home, I know that's a little bizarre, but I always want to make myself open for questions. And if there's any questions that are in the audience, I'm happy to answer them. I will be available live on site in Naples on the program on the day of the lecture that's being scheduled. So again, thank you very much for the opportunity. I appreciate you taking the time to participate in this lecture on head and neck cancers. What do you need to know for the front line? A primer for ARNPs and PAs. Thank you.
Welcome to this recorded session. The presentation you're about to hear is titled Current Paradigms in the Treatment of Head and Neck Cancer. The two of us put this presentation together. My name is Matthew Mifsud. I am an assistant professor of otolaryngology at the University of South Florida, and I work with our head and neck oncology and microvascular team. And with me, I have Hock Dang, who's a PA who's worked with us, quite frankly, for longer than I've been a resident, and her main focus has been head and neck cancer. So hopefully we'll have a good amount of experience from different sides today. And we have no relevant disclosures. So I always start with this basic story. It's one I tell our residents a lot about. It's a 70-year-old gentleman who came in after about a year delay of facial paralysis, eventually found to have a cancer of his parotid gland. And he had a really extensive treatment, parotidectomy, radiation, the works. Unfortunately, about 2 years after that, he died from metastatic disease. I tell him about this case because it's my uncle, and I think it also says a lot about head and neck cancer. And you can see he went from being a really vibrant guy, used to play soccer in college, to really being eaten away by his cancer. And I think our head and neck cancer patients have a lot of challenges. It's a very rare group of cancers. They're often misunderstood. A lot of radiation oncologists and medical oncologists really don't have a lot of good experience. And the other problem with these cancers is that many of our patients have lifelong challenges. They can't swallow, they can't work, they have changes in speech, and many have disfigured. The other problem, I think, with head and neck cancers is that there's not one type of cancer. You know, lung cancers are very algorithmic. Breast cancer, there's different entities, but it's breast cancer. For head and neck, it's really a group of many different cancers, but they all happen in one region. And I think this variability is very confusing. It's confusing to physicians and surgeons, confusing to patients, confusing to all of this. And I think if you want to break it down, I think the natural history, the anatomy, the pathology, all of that is really how we decide to treat these and to stage these. And when we think about head and neck cancers, this is sort of an amalgamation of what's out there. You have your mouth and oral cancers, the nose and sinus, larynx, skin cancer, salivary, and then others. And this is sort of a breakdown of that. And today I think we're mostly going to focus on the traditional air digestive tract cancers, with the exception of oropharynx. I know Dr. Magnuson should hopefully shortly be giving a talk on transoral robotic therapy and oropharynx cancer, so I didn't focus too much on that to avoid redundancy. And kind of looking at paradigms in treatment of head and neck cancer, this is really what we have. There's surgery, there's radiation, there's chemotherapy and immunotherapy. When we look at chemotherapy and immunotherapy, for the most part, these are things that are supportive of surgery and radiation. And with everything changing in immunotherapy, this really hasn't changed. So the bulk of our talk today is really going to be talking about surgery and radiation, because really chemo and even immunotherapy, even though they're hot topics, they're really only still supportive topics in day-to-day practice. So the objectives that I kind of have listed here, first is to learn how to effectively stage these cancers, and we're kind of pinpoint some of the key focuses here. I put a little bit about the unknown primary, what to do about the neck mass, the neck node, how to manage that. We'll talk a little bit about when primary and adjuvant radiation are appropriate, and there'll again be some case vignettes about that. And then finally, we'll look at appropriate post-op treatment. So Hock's going to take us through basics of staging.
Good afternoon, everyone. Thank you for having myself and Dr. Mifsud present at this meeting. General head and neck staging is, I group everything together as in this slide that you can see here. T1 is usually a tumor that we cannot find out where it is. TIS is something that is very small, very superficial. A T1 tumor is usually less than 2 centimeters in size. T2 tumor is between 2 and 4, but no greater than 4. And then a T3 tumor is greater than 4 centimeter. And then the most advanced, we're looking at what we stage as a T4, which is moderately advanced and invading adjacent structures. Some pretty basic nodal staging in head and neck cancer. NX means that clinically we cannot assess whether the patient has lymph nodes or not. This would be revealed when we order new imaging. N0 neck is no distant disease in the head neck area. And then moving on to N1, just a single lymph node, usually less than 3 centimeters in size, contained to the lymph node itself without any extension into the surrounding tissue. N2A, another single lymph node, greater than 3, but less than 6, also without any extension into the surrounding tissue. N2B, several lymph nodes, all of which are less than 6 centimeters in size, contained to the lymph node itself. Moving to N2C, you have disease in both necks, all the lymph nodes are less than 6 centimeters, contained to the lymph nodes. And then the most aggressive neck disease are the N3s, which are greater than 6 centimeters, and the lymph node is pretty stuck to the surrounding tissue in the neck area, making it difficult to dissect.
So I think we want to talk specifically about oral cavity cancers because they're a little bit unique. And you can see, this is a picture I found and how can help you put together, that there's many different subsites of the oral cavity. Each area is a little different. So I want to start with this first case. This is a very young girl who came to me with what looks like a relatively small oral cavity cancer, but you can kind of see on this CAT scan, it's fairly deeply invasive and crossing the midline. She's only 19 years old. So we actually took her for a partial glossectomy and a neck dissection. I did a reconstruction with a 5 flap. And I apologize, a lot of my cases weigh heavily to free flaps, and that's just a sort of what is in my heart, and that's what I take my best pictures of. So I apologize. I'm not trying to advocate that everyone needs a free flap, but it's where my sort of best cases are. But when we look at the path here, we can see it's a mid-sized cancer, 2.9 centimeters. A big key here is that it's a very deeply invasive cancer, 15 millimeters in depth. And despite the fact the CAT scan was negative in the neck, she did have 1 lymph node that was positive. And we staged her as a T3N1, so this actually would be a stage 4 cancer based on our staging. And she went through radiation and is now recovering. You can see this is her with her free flap. And one key thing about her surgery is functionally, even 1 month out, she was doing quite well. And if this will play. What are you eating? I'm eating rice. I started eating you can see, she has a little bit of a slurred speech and she's got some challenges ahead of her. She's doing better now. But even a month out with the right surgery, the right healing, we can get them functioning pretty well. Hawk, do you want to talk a little bit about depth of invasion?
Yes. Depth of invasion has become a pretty important parameter to a very important predictive parameter in the aggression of head and neck cancer. With the introduction of the AJCC 8th edition of head and neck cancer staging, they've introduced the role of the depth of invasion, which is abbreviation is DOI. So DOI is now used in conjunction with tumor size because head and neck is more of a surgical specialty. Most of our cancers in the oral cavity will require surgery. So we have a more robust pathological and staging information. So the patient is staged either, first of all, clinically based on exam and the greatest dimension of the tumor on exam in the office. After surgery, after the tissue is obtained, we can get a better pathological staging of the tumor, incorporating the size of the tumor plus the depth of invasion of the tumor. Now, depth of invasion is not describing tumor thickness as most people may think it is, but it actually measures the level of the basement membrane of the closest adjacent normal mucosa. So with the advent of the depth of invasion, we are looking at cancers that can be increased in tumor size. For example, without depth of invasion into consideration. A tumor that's initially at stages of T1, such as less than 2 centimeters in size, clinically with the judgment that it is less than 5 millimeters in size in depth invasion, we would stage it as a T1. However, after surgery, once the tumor is removed, even though the tumor is less than 2 centimeters in size, based on pathology and histology exam, if the tumor depth of invasion is greater than 5 centimeters, even though it's a tumor that's less than 2 centimeters, is now staged as a T2, and so forth.
Yeah, I think the real important part about that staging is that once you have a depth of invasion greater than 5 millimeters, the risk of lymph node metastasis is pretty high. And if you don't treat that neck, you end up in trouble. It's something that really is important, and we often see recurrences because that's not been addressed. I think, Hawk, you had mentioned a nice slide here about mandibular involvement. And I think the key with all this is that when you have a cancer that's kind of sitting or abutting the mandible, that has to be treated, and that when we do have these mandibular cancers, their risk of recurrence is much higher. You want to talk a little bit about different treatment options for that, Hawk?
Yes. So with mandibular cancer, let me see.
I think I flipped the slide on you there.
Yeah. So there are different, when we're talking about mandibular cancer, we're looking at different regions in the oral cavity. There are 4 subsites that we need to consider. One of them is the mandibular alveolar ridge. Number 2, the lower buccal sulcus. Number 3, sublingual sulcus. And number 4 is the mandibular retromolar trigone area.
And what we were kind of showing in this slide is that if that mandible is involved, there's not this layer of healthy tissue between the cancer and the bone, you need to really address that. And I've seen a few patients where they kind of do a partial surgery and they leave some cancer behind, they try to radiate, and the problem is these patients just don't heal very well. And even if the cancer goes away, they get osteonecrosis. So this is an interesting case. And again, when you look at this through the mouth, it looks more like a tongue cancer than a mandible cancer. But when you look at the imaging, particularly the sagittal imaging, you can see that the cancer is very clearly abutting the bone. And as Hawk kind of pointed out in her slides here, if there's not a clear plane here, you're going to have to do something with the mandible. In this case, we chose to do a marginal mandibulectomy and actually preserve most of the mandible. So you can see he had a marginal mandibulectomy, he lost a bunch of his tongue. We didn't just primarily close this, we put again another free flap in. And he actually had 2 nodes that were positive. He had a pretty advanced cancer, but luckily that bone in itself wasn't involved, but we took that bone out to clear the margin. And I tried to send him for radiation, again, because he had lymph nodes and high-risk features, but he was kind of a crusty old guy and got through a bunch of treatments and just bailed out. Next case I want to give is about our unknown primaries. This was a healthy female, 3 months of a left neck mass, 6 years old. She's gone through multiple courses of antibiotics and all this without change. And you can see what looks like a fairly benign looking cystic lymph node. The problem is in adults, most of these are going to be cancers. And I think you really have to think in your head, what are you going to do to prove that without misdiagnosing them? And these are sort of the steps I think of. Look for the primary if you can find it, select the right imaging, and then either refer them out or treat them appropriately. So, the primary is, again, you're really doing a really comprehensive exam to look for something. You want to make sure you scope them. You want to look at the nasopharynx. You want to look at the piriforms. If you have to, take them to the operating room for a direct laryngoscopy. You want to try to find a primary if one's there. And you want to think about some suspicious findings, things that, maybe aren't as obvious as that picture I showed before, the asymmetry of the tonsil, firmness if you get along the back of the tongue, any asymmetry of movement of the palate. If you've got, obstructive masses or a unilateral fusion, these things really have to make you think of cancer. Imaging is important. I use a lot of ultrasound in my clinic because I do a lot of my own ultrasound. However, it's very opera dependent. And I rarely will send anyone for radiology guided ultrasound because I just don't think you get a very good answer. So that really leaves you with CAT scan or MRI as your primary treatment. I like CAT scan a lot. It's relatively short to do. It's a lot less expensive than MRI is. It's better with mental or general artifact. And for the nodal disease, I think it gives you the best bang for your buck. MRI, on the other hand, is probably a better study, gives you much better soft tissue definition, and it's really good for skull-based tumors, cranial nerves, in theory for a tongue tumor to define the actual extent of tumor. However, it's much more expensive. Patients don't like it because it takes a long time. It's often hard to get a really good image, especially on my computer screen, and it's a lot more issues with implantable devices. So I use MRIs more judiciously than CAT scans, which is why all you're going to see in this presentation are CAT scans. And then PET scan, I think, for neck nodes is really important. It's really good at showing primary lesions under the surface. And oftentimes, if you have a neck node that you can biopsy with a fine needle aspiration and then a good PET scan, that on its own can almost define your treatment. The biggest problem I have with PET in our practice is sometimes insurance just won't cover them. So something you got to work with. Fine needle aspiration is great, high degree of accuracy, great safety profile, and often can expedite care. The one hesitation with some of these cystic lymph nodes is from time to time, you just can't get a good sample. So in this patient, that's sort of what happened. We didn't have a good FNA, but I kind of knew that they were cancer. And I also knew this was cancer that we probably could treat surgically. So we started out with a neck dissection. I didn't just pluck the node out, but we did do a formal neck dissection. We staged the tumor. We found out that it was in fact HPV positive oropharynx cancer. You could then debate about the different treatments, but she went on to have a transoral surgery to the primary site, which is sort of like a basic tongue primary, and she was treated with surgery alone. The last thing we really want to talk a lot about is larynx cancer, and you can see there's multiple subsites. And I think, Hawk, the one thing in this slide I think we should point out was that T3, T4, if you kind of touch base on that.
Yes. So larynx cancer is very tricky. We have to start with a very thorough flexible fiber optic exam in the office. Sometimes you can see an obvious tumor in the larynx, sometimes you can't. In that case, either way, you would need to take the patient into the operating room for a comprehensive exam, which will involve a pen endoscopy with superficial and deep biopsies. So T1 tumors are very small tumors, very superficial. T2 are a mid-sized tumor with significant depth of invasion. The T3s are the most involved in the sense that the vocal cord is now paralyzed, the patient is hoarse. There's some invasion into the paraglottic area and pre-epiglottic space, and oftentimes the thyroid cartilage is either involved or destroyed. And a T4 larynx cancer has grown outside of the voice box and is grown through the thyroid cartilage and surrounding areas such as the thyroid gland, oftentimes the trachea, esophagus, and even the upper tongue and neck muscles.
And I kind of put this as a basic outline for larynx cancer treatments. And I would say for T1, the true glottic cancer or small primary, pretty much anything you do is going to have a high success rate. And that could be transoral laser section, radiotherapy. For the T2 to T3 tumor, for the most part, it's actually going to be chemoradiotherapy. There are some types of laryngeal surgeries. There is some transoral surgery you can do for these cases, but usually those are very selective groups. And for the most part, you're looking at chemoradiotherapy, except for very large T3s. And then for T4, for the most part, if it's destroying the voice box, you really need to do surgery, and usually that's going to be an upfront laryngectomy followed by radiation. And this is a case I wanted to illustrate I thought was interesting. 57-year-old guy. He was initially staged outside as a T1A, but he came to see me and I was looking at him in the clinic, and he really had some subglottic extension. So it was really more of a larger T2 tumor. And you can kind of see that in this PET scan. It's creeping below the vocal cords. And he was treated with radiotherapy. You could argue for any chemo, but that's a separate discussion. So he initially did really well. I saw him about a month post-op. He was doing great. But now he's starting to get this stridor. His vocal cords aren't as mobile, a lot of swelling. So the question is this a treatment-related impact, or is this cancer? And it could be either. Unfortunately, this gentleman is really averse to getting treatment. He really needs a trach. He's actually moving to Houston, so I don't really have an answer to it. But it really brings up something that Hawk really wanted to push forward here, which was this idea of functional larynx. And it's not just about curing cancer, it's also preserving function. And you can kind of see what we put here is that all these different functions that the larynx has. And these are some of the adverse impacts that radiation can have. And I don't know if Hawk, you want to kind of go through this briefly.
Yes. Patients will often have what we describe as stridor, meaning more inspiratory stridor because of all the swelling in the voice box after radiation. They also have a tendency to complain at almost every visit about severe throat pain, which is very difficult to treat. They also have very difficulty in swallowing, even thin liquids such as water, some neurotoxic reactions such as chronic pain in this area. And most importantly, their airway can be very narrow due to chronic swelling, fibrosis of the intrinsic laryngeal muscle, causing the vocal cords to be very stiff. And this can also lead to a compromise in their airway.
And, you know, when we think about how to treat this, there are some patients that even if they've been cured from cancer that still need an operation. And it's also one reason to really select who you do treat with chemoradiation. And that's because you can't really survive with the non-functional larynx. You're often G-tube dependent and you often have a trach. As Hawk kind of pointed out on this slide, some of them even have recurring aspiration pneumonias. So many of these patients really do benefit from a laryngectomy, and frankly, their function when it comes to swallowing and even speech with some of the prosthetics we have and electrolarynxes we have really can be better than they were before. I had a case of a high-risk skin cancer. I think for time, we're going to move on for that one. And if we're lucky, I'll be able to present this live at the actual conference. So this is a slide that looks at post-treatment surveillance. And these are all cases I did in my first year of practice, who I now took pictures of over the last year, almost about 4 years later. I think it's really key that once you treat head and neck cancer patient, they're yours. And the surveillance is really important. Hawk, do you want to talk about supportive care a little bit?
Mm-hmm. Like Matt said, these patients become yours forever and ever. They always complain about the same things. And so I'm just going to go over some of the things, the more common things that they tend to complain about. Number one, they complain that their voice is weak or they can't swallow. So you have to consider sending them to a speech pathologist to work on improving their swallowing and work on improving their speech. Weight maintenance is also a problem due to difficulty in swallowing. So we want to make sure that they have the necessary needs to talk to a dietitian so that they can come up with a nutritional plan so that they can maintain their weight. Also related to swallowing because of scarring of the esophagus, the pharyngoesophageal area. We oftentimes at Moffitt will send these patients to endoscopy for serial dilations. Head and neck radiation chemotherapy to this area can also cause them to have eustachian tube dysfunction or decreased hearing. So we have to make sure that they get at least a baseline hearing evaluation, if not an annual hearing evaluation. Family support can be very limited in these head and neck patients. So we have to make sure that there is a social worker or a case manager that they can talk to concerning some of the medical needs, such as transportation to their visits, social needs, and emotional assessment. As you know, these patients deal with a very tough disease, and it can be very hard on them, especially when their social support is very limited, as most of our patients are. And lastly, they talk about not being able to chew because of prior surgeries, and they always want teeth or dentures. So just make sure that they are referred to an appropriate dentist or prosthodontist to fabricate new dentures, bridges, dental posts, or obturators to help with chewing.
And then this I thought was a good overview of some follow-up. Do you want to go over this quickly?
Mm-hmm. At their annual visit, we always like to make sure that they either get a CT of the chest for lung cancer screening, as most of these patients are former smokers. Worst case is a chest x-ray. We also make sure that their thyroid function is working, so the TSH level needs to be checked at least every yearly by us or by the primary care. CT, MRI, depends on level of concerns, how compliant the patient is as far as follow-up is with you. PET scan, typically ordered after post-treatment, usually 12 weeks. We don't order it too much unless there is a new concern or physical finding post-treatment. And lastly, ultrasound is very underutilized. As Matt said, he likes to use it. And I also like to order it very often. It's good for overall neck surveillance and to evaluate for adenopathy or very vague neck fullness that patients like to complain about.
And then I kind of broke down our follow-up algorithm. There's obviously some, this can be debated in different institutions, but I think this works well for us. I mean, for the first year or two, you really need to see these patients every 2 to 3 months. That's because the majority of recurrences for head and neck cancers happen early. So you really need to keep them close those first 2 years. In the 3-year to 4-year range, we start to spread out 4 to 6, then to 6 months, a little depending on the patient. Some people really don't want to come back and they spread them out a little more. Some people are very anxious and really want to see you more. And I think you kind of gauge that based on your concern and their concern. And then at 5 years, I think our party line is they can see us if they want, or they can kind of head off. But many of these patients, particularly those that end up with complex surgeries, will often come back once a year because they have unique needs, unique issues that just no other type of physician knows how to handle. I think the one last staying point in this presentation really has to be, if you're going to be involved in taking care of head and neck cancer patients, you have to be the ones that keep managing them pretty much for the rest of their lives. I can't tell you how many patients I've seen that refer to a radiation oncologist, had the radiation, never saw an ENT, and then come as a referral to us too late down the line with problems or recurrences. And I think as an otolaryngologist, someone working with ENTs, you really have to think, if this is a patient that you're going to take on, you need to make sure it's your job, because of all the skills that we have, to really follow these patients. So I think we'll end there. We thank you very much. And hopefully some of us will be doing this live in Naples. Bye-bye.
Thank you, everyone.
Hello, I'm Scott Magnuson. I'm a head and neck surgeon at the Advent Health Cancer Institute and medical director of the Advent Health Nicholson Center. Today, my presentation will be looking at the current state of the art in robotic head and neck surgery. I have these two disclosures, however, they have no impact on my presentation. Transoral robotic surgery began in 2007. There were 3 institutions who were performing head and neck transoral robotic surgery using the Da Vinci robot. University of Pennsylvania Medicine with Greg Weinstein, Bert O'Malley, the Mayo Clinic with Eric Moore, and also the University of Alabama, Birmingham, which was my home institution. We gathered data on performing transoral robotic surgery using the Da Vinci platform on patients and collected this data that was submitted in 2009 to the FDA. And this was approved by December 2009 by the US FDA for tumors of the oropharynx, that is the tonsil area, base of tongue, and supraglottic larynx, for T2 and T1 tumors, as well as benign tumors of these areas. Since 2009, there have been an explosion or an expansion of the use of the Da Vinci platform in head and neck. Transoral robotic surgery, originally used for those benign tumors and T1 and T tumors, expanded into larger operations to include total laryngectomies, hypopharyngectomies, operations in the parapharyngeal space, even nasopharyngectomies. But beyond the oropharynx, the robot has been used for neck dissection, thyroidectomy through a transaxial approach, then a transcervical approach, and most recently a transoral approach. Also submandibular gland excisions and microvascular reconstruction. So as you see, for what we began in 2007, a very limited number of operations performed, this has really expanded into a large number of procedures in the head and neck. I'm specifically going to talk about this patient here, and this patient is the most common patient that we see for transoral robotic surgery. It's a patient who is 63, middle-aged. He has 1-month history of a right neck mass, and that's the most common presentation in these patients. No aerodigestive symptoms, and I'll stop my video. He quit smoking about 20 years ago. He does have a history of radiation to the tonsils in the 1960s for tonsillitis. And he had a biopsy of a lesion in the oropharynx that was positive for P16. That means it was HPV-mediated oropharynx squamous cell carcinoma, as well as a confirmed squamous cell carcinoma from a fine needle aspiration of his neck. Now, as we look at this video, you'll see as we pass into the nasopharynx and in the oropharynx, there is a mass extending from the right glossotonsillar sulcus. It looks to be passing midline. It does touch the epiglottis. We see the larynx is nicely open. We come back and have a closer look, and this tumor is a very exophytic type of tumor that's beginning from the lateral aspect of the pharynx, extending into the oropharynx. Now, if we check out a video on this patient, we see the similar findings. And if this patient was seen by radiation oncology, consider the field that this person would have to undergo for radiation therapy. The radiation field would have to cross the midline of the tongue base. It would have to cross the midline of the posterior pharynx, and that will have significant impact on the patient swallowing in the future. There's a great option for this patient, and that is surgery. We perform 2 operations at the same time. We perform a neck dissection to remove the lymphadenopathy from the patient's neck. We address the lingual and facial arteries in that patient by clipping them so that there is decreased high flow blood supply to the oropharynx, and we perform a transoral robotic surgery in this patient. What that offers the patient is an opportunity for significantly reduced adjuvant treatment in a setting where the primary chemoradiation might have a significant impact on his swallowing. And so, as I said, I perform a neck dissection first, and in this case, because it was in the glossotonsillar sulcus, the hypoglossal nerve is very close to that from the neck side of the wound. And to protect the hypoglossal, I place a thick piece of alloderm, that's an acellular dermal matrix. I place that into the neck underneath the hypoglossal, so that when I go to do the operation from the pharynx, you see I come across this alloderm, and I know the hypoglossal nerve is protected. So I can safely resect this tumor from the glossotonsillar sulcus, the hypoglossal nerve is protected, and we get a nice clear margin. So here's the pathology from this patient. His primary site is 3.5 centimeters, P16 positive. The closest margin was 2 millimeters at the deep margin. He had 2 lymph nodes positive in the level 2 part of his neck with a larger node at 3.8 centimeters. The remaining nodes were negative. There was extracapsular extension of 2 millimeters with 3 millimeters in length. And so that's a two-dimensional description then of the extension of that tumor. Now, why is this patient different than those that we saw in the 90s and even the 80s of squamous cell carcinoma? And the primary reason is this disease is HPV mediated. And we know from this study from MD Anderson that the P16 positive survival curves are much different than those patients who are smokers and are not HPV related. So within these patients, does extracapsular spread make a difference? And the answer is there is a difference between these patients and the importance of extracapsular spread. In the P16 positive patients, if you look at the survival curves, there is no difference between those with extracapsular spread or not, unlike that in the P16 negative group. And this is confirmed in another study. This study, it was published in Cancer. This came out of Washington University. They looked at the impact of extracapsular spread between the two groups and really saw no difference between their survivals. And if you take all of the patients with extracapsular spread and you add chemotherapy to the treatment in the adjuvant setting, they found no impact from the addition of chemotherapy with the radiation in the adjuvant setting. So this is a different disease than we see in those patients who are P16 negative. What is important? And that is nodal status. One of my buddies, Chris Holsinger, looked at 12,000 patients from the SEER database in the US, and he found that greater than 5 lymph nodes, metastatic lymph nodes in the neck, was associated with poor decreased survival. This was also confirmed by a study that came out of Washington University. Again, Bruce Hoey, my colleague. He also found that greater than 5 nodes lessened the prognosis for survival. In our own data, if we look at those with less than 4 versus greater than 4, we do see a significant impact on the number of nodes in survival. So nodal disease, the number of lymph nodes, is important in these patients. What about contralateral nodes? What do we have to do about the contralateral neck? Many times patients are treated bilaterally, even if it's adjuvant setting with radiation. And how important is that? Well, if the tumors are very lateralized, and we'll say to the tonsillar fossa, this study from MD Anderson looked at 900 of their patients with tonsillar cancers. 102 of them were only treated unilaterally, and they found that in 102 of them, only 2 patients had a contralateral recurrence. One of the recurrences was in the tongue base, so it was probably not a recurrence but a second primary. This was confirmed in Melbourne, Australia, where they also looked at people with unilateral tonsil cancers. They found no contralateral recurrences. So in order to change our strategy for treatment, this clinical trial was opened and it closed to accrual, ECOG 3311. And it looked at reduction of radiation for those patients who fall in the intermediate category. And that is this group of patients in B and C. So the B group, they received 50 gray of radiation and 25 fractions, where the C group received the standard adjuvant dose. And there was no difference by decreasing that adjuvant radiation in that patient population. So this supports lesser treatment. Pathos is another trial that's currently accruing patients, and they've added an arm to look at the impact of chemotherapy. So in that high-risk group, they're randomizing the patients to chemotherapy. So hopefully we'll have an answer soon on the value of chemotherapy, like we already know with radiation, that it's possible to reduce their dose of radiation. So today we're sitting at level 1 at levels of autonomy in robotic surgery. As described by Science Robotics Journal, level 1 is where it's a master-slave situation, where the surgeon does everything, the robot can only do what the surgeon does. But in the future, we'll be here at the high autonomy and even full automation as these computer systems become more sophisticated. I want to thank you for this short presentation and introduction to robotic surgery currently in head and neck. Feel free to email me at scott.magnuson@adventhealth.com. Thank you very much. For those interested In February 2022, we will be hosting an obstructive sleep apnea hands-on dissection course at the Nicholson Center in Orlando, Florida. Thank you.